Hello, my name is Alan Bagnall. I'm an interventional cardiologist at the Freeman Hospital in Newcastle upon Tyne. Today we're going to be doing a challenging primary PCI case. Our patient is a 74-year-old female who developed acute onset of chest pain at around 7 a.m. this morning. She made a call to the emergency services at around 8 o'clock and the ambulance arrived at 8:15. There they found that she had a history of angina going back over a year and a half and that she was scheduled for a hip operation in 2 months' time. They took the following ECG, which, as you can see, shows a left bundle branch block pattern. They diagnosed an acute anterior STEMI and gave her 300 milligrams of aspirin, some oxygen and some morphine for pain relief, and she was transferred immediately to our catheter lab. She arrived here at just past 9 o'clock and we've done some of the initial setup already. So in place we have an intra-aortic balloon pump that was inserted via the right femoral artery, and that's helped to augment her pressures, and her aortic pressures are now 90/45, but she remains tachycardic with a heart rate of 110. We've taken pictures of the non-culprit artery on the right, which was free of significant coronary disease, and we've approached this from the right radial artery. Generally, I prefer to do my cases via the right radial artery because of reduction in bleeding. In this case, where we have to have femoral access anyway, for the balloon pump, it probably doesn't make too much difference. We've now selected an extra backup 4-guide catheter, and we're going to take some pictures of the left system to diagnose what's going on. I should add that in addition to the aspirin, she's also been given some heparin at 70 units per kilo, and she's been given ticagrelor at a loading dose of 180 milligrams. But for this patient, alternatives might include clopidogrel at a dose of 600 milligrams, and she's just below the age cutoff for prasugrel at a dose of 60 milligrams. So we're ready now to take some pictures. I have myself in the AP caudal view, which is good for laying out the left main stem. So here's our first injection. And I tend to leave my foot on the pedal for a good while during those ones, just to see if there's any penetration of the contrast through the obstructive thrombus to try and get a better roadmap of where I need to maneuver my wires. In this position, in this view, we can see that the LAD heads up towards the 1 o'clock position and the circumflex heads down towards 4 or 5 p.m. position. And we can see that the circumflex is occluded. The LAD, I've got suspicion in this view that there may also be some stenosis in the mid-vessel just around about the origin of the diagonal. So I'm going to now come into a PA cranial view, and that'll help to lay out the LAD a little better. Just bring the table down a little bit. Okay. So as we thought, just beyond that diagonal branch, we've got some severe stenosis in the LAD, and that's almost certainly contributing to the how profoundly ill the patient is at this time. So we're going to, she's had some heparin. What we're going to do next is to look at some adjunctive therapy, and we might consider giving some glycoprotein inhibitors. But clearly the first thing that we need to do is to try and get a wire across this lesion and to reopen the circumflex. So the PA caudal view that I took actually show things pretty well. So I'm going to come back and work in that view. Do we have a talking device, please? I've taken a standard 014 guide wire here. This is typically I use a spring-coiled workhorse wire. I tend to avoid using polymer jacketed wires in primary PCI because they have lower tactile feedback and it can be easy to find small branches without being very aware of that. So I'll just feed this in here. I've selected a 45-degree bend on here, which I'm hoping will be sufficient to get me around the bend into the circumflex. If it's not, then we may have to just reshape. So we can see that's entering into the proximal circumflex pretty easily there. And I'm just going to try and gently advance the wire across the lesion. Looks like it's picking up a marginal branch there. And just see if I can take it round a bit further into okay, it's pretty tachycardic here, 200. Just going to take a test shot. And I think she's in, we've got some flow there, but it looks like she's gone into VF here. So if we can defibrillate here, please. It's not uncommon to get some acute dysrhythmia such as this. Okay, well that was exciting, as these things always are, and she's now back into sinus rhythm again. Still fairly tachycardic, hypotensive as well. But we saw that we managed to get some flow in that artery. And we've got a little bit of a roadmap so we can take this wire down a little further into the artery. Okay, I'm going to give some glycoprotein inhibitor just now. So the options might include abciximab, tirofiban or eptifibatide. And that's just been administered there. And I'm going to take another angiogram to see where we're at and what sort of stenosis we have. Okay, so we've got a little bit of flow here. So even with those extra medication, still haven't got full flow. So I think what we'll do is perform aspiration, try and do thrombectomy. There are a variety of different makes of aspiration catheters. They all follow the same basic design, which is a hollow tube to which you can add a three-way tap and a syringe which can be locked on negative suction. And when you have got the aspiration catheter into the coronary artery, you can then open up the three-way tap to start sucking out the thrombus from the coronary. So all of these in fact are on a rapid exchange system. If I could ask you to fix my wire there, please. And we're going to take this up now into the coronary tree. You can see it coming down the guide catheter here. So just as we get round the bend, I'll ask for the aspiration to be started off. And we're aspirating now. So what I do is slowly advance the aspiration catheter across the lesion. I'm getting some resistance to forward motion there, probably because this is quite a tight stenosis. I'm just going to try and make another pass there. If we could aspirate again, please. And it's quite a bit of resistance at that point, so I'm not going to push things. If there's a tight stenosis there, I don't want to cause any dissection of the artery by forcing the aspiration catheter anywhere it doesn't want to go. It's very important that we keep our negative pressure on throughout the time that we withdraw the catheter, withdraw the thrombectomy catheter from the guide catheter, and that's just in case there's any thrombus that's on the end of the aspiration catheter. If you turn off the suction, it could get dropped inside the guide, and you could inadvertently inject that next time you take an angiogram. So to be doubly sure that there's not any thrombus, or there hasn't been any air entrained into the system during removal of the thrombectomy catheter, I typically will bleed back from my co-pilot or aspirate from the sidearm. So let's have a look now and see whether that's done the job and got some better flow down the circumflex. So that looks a lot better in the circumflex, but we can see that we've got quite a lot of spasm in the left main stem, which won't be helping matters at all. So I think what we'll do, our pressures are a little bit low, but I'll give a little bit of nitroglycerin here, intracoronary, and see whether that improves matters. I'm just going to back off my guide catheter a little bit because it's a little bit deeply engaged there, and that might be one of the factors that's contributing to the spasm. Okay, just make sure this, if you move your guide catheter back, your wire starts to migrate forward, so you just need to be aware that the whole system, what it's doing. So let's take a picture now. Okay, so that spasm in the left main is a lot better, and our pressures are beginning to improve as well there. So they're 90/45 now, which is a lot more comfortable situation. So we now have to decide what we're going to do about this lesion. Options are obviously either to predilate the lesion or to directly stent. In this case, we were unable to get the thrombectomy catheter to go across the lesion, so I have some concerns that I might not be able to get a stent across without some lesion preparation. We have to balance that against the knowledge that for each manipulation you do at the lesion site, you're likely to get more distal embolization of any residual thrombus, because certainly the thrombectomy catheters do not remove all of the thrombus that's present at the lesion. So I think what we'll do is we'll just try to deliver a stent first. If we have any problems, we can always come back and predilate. Now, if we review our angiogram, before we do that, we decide on our stent sizing. I'm going to give a little bit more intracoronary nitrate, just so that the vessel has a chance to assume its full size. So we're just select that on here. We'll give 150 mics here. I can, depending on the case and the patient's blood pressure, I can give anything up to about 1 milligram of nitroglycerine. Clearly in this case I wouldn't do that because the pressure's too low, but we've given another bolus there. And we'll take another picture and assess our size. So it's a reasonable size. I think probably we'll need something like a 3.0 for this, and lengthwise we're probably looking, if we could just bring up the picture of the lesion again, probably a 12 to 15 millimeter. I think I'll do is I'll take I think a 12 millimeters should be sufficient for this. If I could have a 3.0 by 12. Now we know that this lady has got surgery coming up within the next 2 months. That's almost certainly going to be cancelled in view of the fact she's had an MI. But even so, that hip problem's not going to go away, and at some point the orthopedic surgeon's going to want to not be taking dual antiplatelet therapy. So we may be best off in this situation to just select a bare metal stent, even though that comes at a slightly higher risk of needing target vessel revascularization at a later date. So we've selected a 3x12 stent. Just feed it onto the wire, and if you could fix that wire for me, please. Okay, I have the wire now. Oops, sorry, I just took it a little bit far in there. So let's have a look at our stent positioning. Looks pretty good. I think we're across the lesion there, and I've got a good landing zone either side. So I'm going to deploy the stent now. Then, as you saw, actually went across without any problems. They've got a lot lower clotting profile than the thrombectomy devices. And I've got our stent up there at 14 atmospheres. It's telling me I've got it a little bit oversized. And typically I'll leave that up for about 30 seconds, but we'll do it a bit quicker for this one. Now, I had a little warning that it was oversized, so what I'm going to do is that when I take a test shot, I'm leaving my balloon inside the guiding catheter, so if there is any problems with perforation, that I've got a device there that I can tamponade the vessel straight away. Let's see how it looks. Yeah, it actually looks pretty good. We've got nice flow down in our circumflex there. If I was being hypercritical of this, I would say that the stent may look a little bit underexpanded in that area. And again, you have to make a a decision at this point about whether you do further post-dilation of the stent and risk further embolization downstream with the potential consequences of getting no reflow, or whether you accept what you have. I think in this case we've actually got a pretty good result here, and we've got TIMI-3 flow, and we shouldn't lose sight of the fact that this patient was presented in cardiogenic shock. And one of the next question comes in patients with cardiogenic shock is, what do you do next? Do you wrap up the case at this point, or do you try and optimize things further by completing full revascularization for the patient? Generally, the recommendations are, if they've still got cardiogenic shock despite the intervention that you've already done, that you should proceed to do complete revascularization. And we saw that this patient had a very severe stenosis in the LAD. There's a bit of information more recently from the PRAMI trial that says that doing non-culprit lesion angioplasty during primary PCI may offer some benefits. We're awaiting further trials in this area, but certainly one single trial thus far has shown that revascularizing the entire tree can be something that helps prevent early events after stemming. So what I'm going to do is just take my my stent out of the circ. Okay, so what I'm going to do next is just withdraw the wire from the circumflex. I'm just going to leave the wire just inside the stent. We're just going to make sure that we've not got any dissections beyond the stented segment. And that looks absolutely fine there. Okay, so what we're going to do next then is to perform PCI to the LAD. And just have to redirect the wire this time into the LAD rather than the circumflex. So that's what means the proximal LAD. I'm going to change positions now. Come into a PA cranial view. And I'm just going to remind myself of the room up here because I haven't got my guide catheters just diving in a little there. Okay. So we had a lesion in the LAD just beyond the diagonal branch. And as you're going down, you're just making sure that you're not picking up any side branches, and that looks like it's going off into a side branch there. If you're not clear at any point, little puff of contrast. Yeah, you see we've just picked up a side branch after the bend there, so we'll just redirect and round again and just steered past our problem. Oops, sorry, we just again got into a little side branch. Okay. So again, I'm just going to take another angiogram here so I can assess lesion length and vessel diameter. I'm going to come into an RAO cranial view which will just lay out that mid part of the LAD a bit better. Okay, so looking at that, we've probably got a lesion length, again, of about 12 or 15 millimeters. Vessel's quite a bit smaller there at that point. So I think what we'll do is we'll take a 225 by 12 balloon. The lesion here looks a little bit tight for being able to deliver a stent across. So I'm just going to prepare it first. Obviously less concerns in this vessel about embolizing thrombus. This isn't the culprit lesion, so we don't need to take any shortcuts. We'll just adequately prepare our lesion and optimize it all for stenting. So I don't know why I just came a little bit forward there around the apex of the LAD. The guide catheter again is wanting to deeply engage, just need to be careful of that. Let's see if we're in the right spot. Maybe just back a little bit. Yeah. So we'll deploy our balloon there. And there we go. So we're up at 8 atmospheres there. And we come down. What I tend to do is to let the balloon deflate fully, but leave the balloon in position when I take my next picture so that I've got the balloon markers showing me how long a stent that I need to use. So here's our next angiogram, and that's great. We've got some dissection of the distal vessel there, which is the kind of thing you don't want to happen when you're doing non-culprit lesion during primary PCI. So what that means is we're going to need to cover that area of dissection as well, which is going to involve a longer stent than we'd initially intended. So I'm just going to bring out, maybe I'll just take my balloon down here a little bit further and just give a little bit of balloon in that segment there, just to make sure that I can deliver stuff. Just going up again with the balloon here. Just at 6 atmospheres there. And back down again. Okay. So let's take this stent out. So in terms of our total length of lesion, we've probably got at least about 28 millimeters, I would say, there, that we need to cover from where the lesion originally was to the point of distal dissection. And I think what we'll do is we'll take a 225 by 28 bare metal stent again, please. Remember, we were choosing the bare 225, please. Or 25 by 28, because we don't have a 225. Okay, let's hope this is not too big. My plan was to the pressure device, is that not down? Okay. So we've got our stent selected now, bare metal stent, 2.5 by 28. Thank you very much. Yeah, so the reason we selected a bare metal stent originally and now for this case is because the lady's got hip surgery planned. The pressure's still reasonably stable here. Here's our stent coming down now. Pressure's dropped a little bit after the issues with dissection in the LAD. So that was just about there, I think. Let's take a look. Ooh, sorry, my guide catheter was very deeply engaged there. It's very important you keep note of all these things throughout the case. And that looks like we're covering both ends of the dissection there, so I'm going to deploy our stent in that position. Okay, I'm just going to 10 atmospheres there is a little bit Actually, I'll go to 12. We'll take 12 atmospheres. And I say normally I'll leave this up for 30 seconds, but I won't do it for this simulation case. I'll just bring back the stent into the stent balloon into the guide catheter. Little test shot just to make sure we've not got any perforation. No, we've still not got a great result down there. Let's take a full angiogram there. It looks like there's still a little bit of dissection in that area. And I guess our question is whether we need to extend our stent any further. Some of the issue here may be with wire biasing. So I'm just going to bring the stent back a little bit because it's on a very tortuous segment. I'm just going to bring the wire back a little bit here. I'm just going to see what that looks like without. I think what I'm going to do is just take a balloon down there again and just give that a balloon at the far end of the stent. The mistake I made here was that I brought the guide wire back too far, and now I've got to cross a lot more of the stent than I would initially have wanted to. As ever in angioplasty, it's the small details that you need to attend to make sure you get the best possible result. With there being some dissection just past the stent here, you need to be very careful with your wiring not to get into a subintimal space and to expand that by taking your wire down further. So what I'm going to do next is take a balloon down. If we can just change over to balloon, please. And we'll take back that 225 balloon. That 12 is fine there. That's great. Okay, that's the right balloon. So we'll take this down, and I just want to inflate this just at the distal end of the stent in case we've got any distal edge dissection. In some cases you might take a stent a bit further down. The vessel's getting really quite small here, and we've already got quite a long stented segment for a bare metal stent, so we'll see what sort of balloon result that we get first. There's our balloon just inflating there. Just got that at 8 atmospheres. And we'll come down again. Bring the balloon back a little bit further. This is the area where it was hazy, just inside here. And we'll take our balloon back up. It's looking better. 8 atmospheres again and down. Let's take a shot now. Certainly the blood pressure is looking a little better there. Okay, that's much better now. So we've got good flow. And we'll take bring the wire back in here again, just to make sure that we're not still got some dissection with the wire out, but I'll come into a steeper cranial view. Okay, let's see how this looks. Great, so I'm very pleased with that now. So we've got TIMI3 flow in all the vessels. Our patient has got a much better blood pressure than when they arrived. Aortic pressure is now 100/60, heart rate is now below 100, SATs are looking good. So this is one of those challenging cases where you've got multi-vessel disease, culprit and non-culprit lesions, hypotensive patients, arrhythmias when crossing the lesions, difficult choices to make about whether to proceed to full revascularization, and as we saw in this case, sometimes that can lead to problems that you need to be able to deal with. But fortunately, we've been able to do that. We've got a great result in the LAD, and I think that's going to give this patient best chance for a great outcome. Thanks very much.